All right, so here's where I'm going to go into our practice resources again, back to the Google Doc. So I've tried to embed the resources we're using today in multiple places so that you can find your way back to the resources. Okay, so here's another place for you to click and find the practice NCLEX questions we were working with before, or to click on the lecture notes. All right, and as long as you have access to these slides, if there are any updates or additions that come to them and you still haven't passed the NCLEX yet or taken it yet, then you're perfectly welcome to use the updated materials as well. All right, so I'm going to make my way back to the Google Doc. All right, and now that we're on, and just for reference, if you wanted to get back there, you could just click here on lecture notes and that would take you back. Okay, so we're back on the Google Doc. Now, so we've taken a look at the Canvas slides. You know how to get to the practice questions, and I did show you the bulleted list that you would see in the NCSBN test plan. All right, so you already know that what this list is all about, and I did give you a list of highlighted items, but there are the details there. It's a pretty comprehensive list. All right, so here we are now at the prioritization situation, okay? Prioritization is a super important category for us to master in order to be great at management of care, all right? That little model that they use to structure your case study questions are really embedded in priority setting, like setting up a hypothesis. If I can just show it one more time here. One of the steps here is prioritize a hypothesis. Prioritize a hypothesis. So they want to know, how do you look at all the clues that you've seen, all the cues that you've seen your patient show, right? Through your assessment findings and your nursing diagnosis, right? How you've looked at those clues and decided, what is the most important thing for me to address? All right, what is the most important nursing intervention for me to make in this moment? As you saw with some of those other practice questions that we were looking at, it's not always cut and dry. It's not always straightforward when it comes to deciding which patient you're going to see first or which assessment finding you're going to address first. Okay, so prioritization is testing how to see you're going to it's testing to see how you're going to prioritize different patients or different assessment findings. All right, so priority answers always have 4 parts. All right, if you are familiar with the Mark K system here, these are some of Mark K's ideas around these, and I really embrace those because Mark K really helped me understand a little bit better how to talk to you guys about the structure, the anatomy of an NCLEX question, and how these priority questions show up, okay? So age, gender, a diagnosis, a modifying phrase, all right? 2 of these items are irrelevant and you don't need to use them in your answer, and that's going to be age and gender. NCLEX is trying more and more to present questions that are not ageist or questions that are not sexist. So they're removing a lot of information around the age of the patient. Perhaps they will tell you what developmental stage the patient's in. Maybe they'll say the patient's elderly. And when they do give you the age, often it's a number that's put in there as extra additional information that you may or may not need to answer the question. Most of the time, you do not need it to answer the question. Besides knowing the patient's stage of development, it's not essential to setting the priority, right? Because it's not necessarily true that if you have a 6-month-old, an 80-year-old, a 16-year-old, and a 35-year-old, how do you determine which patient you're going to see first? It shouldn't automatically be based on age, right? You need other details to figure out which of those 4 patients you will prioritize, okay? So throw out age as a determining factor when you're setting up priorities. Gender works the same way, all right? Because a patient is an older female, right? We aren't going to necessarily respond to that patient first over a, younger male patient, right? Even though we might assume the younger male patient is probably stronger, right? Whereas the older female patient might be, in more dire straits. You have to know other information to make determinations around priority. So let these two be your priority, your priority setting clues. Diagnosis. This is why I believe everyone should learn all the diagnoses. All right. If you want to know more about how I think you can do that, let me know. I could talk with you or share with you a little bit about the study plan. All right. Because when you're studying, I do think you should have a study plan, and that study plan should be focused on covering diagnoses, all of them, as many of them as you can possibly study or cover before you go into the NCLEX. If I throw out different diagnoses to you, you should have something in your mental bank to help you with figuring out what's going well, what's problematic, right? How to identify signs of emerging crisis, right? So know those diagnoses, know them. I do have a kind of an NCLEX planner study guide that I have. It's kind of a fillable PDF, and it has all the diagnoses listed out with some prompts for you to consider what you know about each of the diagnoses. And that's about 200 pages in that fillable PDF. I have a digital version of it if you want to tap into that. Okay, so again, communicate with me by email if that sounds interesting to you. I'm happy to share that with you. All right, so do you know the diagnosis? That will help so much. That'll get you so far on a select all that apply question or a case study question, because you know what you know, and you can tell in the question that NCLEX is presenting to you, well, what's wrong, right? What's off, right? What does not apply. All right, and then finally, a modifying phrase. There's always within an NCLEX question, a piece of the question where everything kind of turns, everything kind of hangs on this modifying phrase. All right. So the modifying phrase helps you decide how you're going to prioritize, and they're always present. Okay. These modifying phrases. So this 10-year-old male with hypospadias who is throwing up bile stain emesis. All right. We've got the age here. We've got the gender here. We've got the diagnosis here. And then we've got the modifying phrase. All right. So if you have an understanding around that modifying phrase, you're already tuned in to the correct way. Okay, Wendell, I got you. So you're tuned in to the correct way to respond to this question, all right? Because they gave you this qualifier here that this kid is throwing up bile-stained emesis. And we do know the diagnosis, so we start asking ourselves, is that a normal part of the diagnosis, or is this an unexpected finding? Is this a sign that this kid is going bad, all right? Or is this unrelated completely and I need to look at other things, all right? So that's what NCLEX is all about. Trying to get you to focus in on the most important pieces of a chaotic puzzle, right? That's why they call it safety, because a safety exam, because they really want to know, are you going to do the thing that keeps this patient's life and limb preserved, right? That's really what safety is. And can you do it in a way that doesn't cause additional harm to yourself or the patient? All right. So modifying phrase, gotta know that. Don't get stuck in the ABCs to prioritize. If you get stuck there, you will begin to get confused. Although that's a good place to start, you need to go deeper. So I'm going to share with you some fine shadings of the priority setting using ABC, airway, breathing, circulation. Yes, if a patient's bleeding, it's pretty important, right? You have to address that. But if they're bleeding, right, but they're also SpO2 or oxygen, we say satting, right, in nursing, but I don't want to use that jargon. But if we have a low SpO2 of 60%, well, that's not compatible with life. Let's give something more realistic of 90%, right? Then we're going to kind of focus in a little bit more on oxygen, right, or getting airway to the patient than the fact that they may also be bleeding, all right, or hemorrhaging. All right, so there's an order to things, but it's more finely nuanced than just the A, B, C's. All right, here's some rules for prioritization that I want to fly through, and then I'm going to take you to the new ABCs, right? The new way to look at extreme scenarios in your patient. Remember that acute beats chronic. Anytime you see the word acute, bring that high up in your list of answers that you want to select when you find that you're dealing with a management of care question or question around prioritization, okay? Because an acutely ill person is always going to be a higher priority than the person with a chronic situation or someone who's been here in the acute care setting for multiple days. All right, if a patient's been stabilized, preparing to discharge, or status post a surgery 5-6 days out, all right, then they're going to be more like a chronic patient than the patient who is acutely ill. All right, and with that said, fresh post-op patients, those within 12 hours of their surgery, they're going to beat out all your other patients. All right. Now, what if you get a question with 4 clients who are all post-op, right? Look for the one that's most acutely post-op, the one that's closest to surgery. Unless you're reading about that patient who just got a surgery, but they're really stable. Honestly, you have to know what stable means, all right? Because unstable is always going to beat out stable when you're prioritizing. Okay, so that's why you need to know the words in a modifying phrase, and don't mix up how severe the symptom is with how unexpected the symptom is. For example, a patient with kidney stones having severe pain, that is a lower priority than a patient with mild chest pains. Okay, because the patient with kidney stones, we expect them to have severe pain. So just because you see the word severe as a symptom for their pain, and you know we want to always address the patient's pain, if it's expected, right? So knowing which diseases have those high pain numbers will really help you here, right? Versus any kind of chest pain with a patient. All right, honestly, chest pain always gets super high priority, even when it's mild. Okay, and they were having an x-ray, so they weren't even really doing anything. All right, so that's how you want to think about that. Now, 4 things that are always going to make you unstable, regardless of whether or not it's expected, will be hemorrhage. There's bleeding and then there's hemorrhage. Okay, will you guys put in the chat for me what you connect with hemorrhage? What words do you see in a question that make you think, oh gosh, this person's hemorrhaging? Just throw the words out there for me. 1 word, 2 words, excessive bleeding. The word excessive, yes, Wendell, alone will make this more closely related to hemorrhage. What are some other ways we can know our patient is hemorrhaging? All right, what other ways can we know our patients are hemorrhaging? I'm going to give you a hint. It's a vital sign. It's a vital sign. Actually, there's about 2 or 3, but which vital signs tell us that our patient's hemorrhaging? Because that's how NCLEX will do you. Ooh, Carissa. Yes, absolutely. In that order, tachycardia and low blood pressure. I love that you know that. I want every one of you to know that, okay? That whenever you see a blood pressure going down while you see at the same time a heart rate going up, you do something. You find a way to show NCLEX, I know this is not acceptable. All right, this patient's losing fluids. All right. And usually the flu, or sometimes, not usually, because sometimes it can be that they've been, that they're losing electrolytes, or that they are diaphoretic, or that they have been vomiting for days in a row. All right. So fluid volume deficit is usually indicated by tachycardia and low BP. Excellent. Excellent. All right. High fevers. That's going to make you unstable. High fevers. All right. So over 105. Now we saw that 101.3 earlier, and that's not so great, right? It's usually telling us that, yeah, that patient has a fever. But when they get into the 103 plus 105 range, you're talking about something unique that is arising in your patient that you really need to pay attention to. All right. And this patient's at risk for seizure, anytime we're hitting those high fever levels. Hypoglycemia, it's a big deal. It is a big deal. Hyperglycemia in the super high ranges that bring about DKA and HHNK, those are big deals too. But hypoglycemia is really something that you have to be able to catch in your patients, right? In real life, not just on the NCLEX. Hypoglycemia sometimes shows up looking kind of weird. Throw in the chat for me a couple of symptoms that you associate with hypoglycemia, right? That cause you to say, this patient's unstable and I need to follow up on this patient. I need to check their blood sugars because they don't act right. Wendell says shakiness. Absolutely, Wendell. That's a great sign. NCLEX might use the word palpitations. They could use the word nervous. They could use the word trembling. Yes, all those words would characterize shakiness. What else are you going to say about your hypoglycemic patients? Because this is a big one, guys. I mean, this is one. Diaphoretic, love it, Melissa. Absolutely. Clammy, I think that's what you're saying there. Clammy, yes. Okay. Clammy and diaphoretic, not good. Diaphoretic is never good. And we want to either, when you see the word diaphoretic or, excessive sweating, you want to respond as if that patient either is having an MI or myocardial infarction or hypoglycemia in the super low ranges, okay? What we don't want is for a patient to go into hypoglycemic shock, okay? Notice that a lot of these unstable conditions here are heading towards shock, all right, of some kind, whether it's a hypotensive shock or hemorrhagic shock, or whether it's a hypoglycemic shock or insulin shock. We need to be on the alert for that. Now we're talking safety, right? Now we're talking safety. So you're going to want to manage the patient with severe hypoglycemia and address that right away. We'll talk about that a little bit more in a second. Pulselessness and breathlessness both require a certain nursing intervention. All right. Does anybody know? What are you going to do if you find your patient pulseless? What are you going to do if you come in the room and you did not witness your patient go down and they are surely on the floor and pulseless? What do you do first?
Call a code.
What do you do first? Call a code. Okay, good. If we're certainly in a skilled care facility, or if we're in a tertiary care facility, we are going to call a code. We absolutely will. All right. So you call a code. What do you do next? What are you going to do next? Absolutely. Absolutely, Carissa and Melissa, start that CPR.
CPR.
Beautiful. Nice. Okay. So you guys are getting it. All right. So the more vital the organ, the higher the priority. Okay. So the organ mentioned in the modifying phrase, okay, not the diagnostic organ, but the organ mentioned in the modifying phrase, the more vital it is, the higher the priority. So let's talk about vitality. First comes brain. All right, brain. So we're talking priority. Which organs are the priority ones? Which ones are you going to respond to fast? Okay, so the brain, because you need the brain for everything else to do what it does. All right, so if you have any indications that the patient is changing in their mentation, all right, if the patient is starting to be confused, all right, that's a big deal response, especially if they were acting normal before, right, or appropriate before, and then suddenly you start seeing signs that may show a neurological deficit or some type of brain involvement. All right, this could show up as a patient who suddenly starts to slur their speech, a patient who begins to become aggressive, and this wasn't the case, or a patient who doesn't know who they are or where they are. Right, this is all called altered mental status. But you could also get a baby with increased intracranial pressure who may start projectile vomiting across the room. So you got to know how brain issues present, right? Maybe they were in a motor vehicle accident and the pituitary gland was somehow impacted. Maybe there was blunt force trauma, or maybe there was a shaking in like a concussive injury, right? All these different diagnoses will have different responses in your patients, but you're going to want to definitely set a priority on any of those neurological deficits that you might see in a patient or any of those signs indicating brain injury. All right. Airway, or the lungs, that's our next priority. All right. Because the brain operates the breathing. All right. So if we're getting a low brainstem injury, right, that's going to affect the breathing and the function of the heart. That's why it's the most priority organ. All right. But then comes airway, right? Airway. And it's important to remember that it's the oxygen that's coming into the patient's body that's actually going to keep the brain working. Okay. So oxygen is light because I meant lighter than air, because you're going to be breathing in and out that precious oxygen to feed the brain. All right, to feed the brain. It's the brain that wants to make use of that oxygen the most. Okay. Of course, we need oxygen everywhere else, but the priority is to get oxygen to the brain. All right. And then the heart, then the liver, then the kidney, then the pancreas. But usually with our priority questions, we're dealing with these three. All right. If you're having, if you need a tiebreaker, right, then you'll think of this order. All right. But usually the modifying phrase tells you all you need to know about what's important. All right. So here is a mnemonic. It's called Ask Graph. This beats out the ABCs: airway, breathing, circulation, as something to help you think through the nuances of priority setting, prioritization, right? What to do first when your patient is going bad. And when I say going bad, I mean they come into your emergency room. I love to have you guys think of yourselves all as ED nurses when you take the NCLEX, or at least when you're studying for the NCLEX. Why? Because an ED nurse is going to essentially see all kinds of patients at all ages and all stages of health status. All right. So if you think of yourself as that kind of nurse, then you're going to understand the importance of learning all the different disease processes. And you won't just limit yourself to things that, an OB nurse might see only, or things that a nurse in a doctor's office might see. Think of yourself as an ED nurse, and you will be more apt to prepare yourself well for the NCLEX. Okay, so you're always thinking about what can go wrong, what did I miss, and what new symptom will cause me to notify the team, notify notify someone else, or make a change in the patient's plan of care. All right, so I'm just going to point out the main letters and what they mean. But again, we're in our last 30 minutes, last 50 minutes or so. And I don't want to rush through things so fast that you don't know what you're looking at, but I do want to keep a track of time so that we can make sure we're covering everything. All right. So airway is super important. I mentioned it before as being a very important piece of the ABC or priority setting structure. It's not necessarily always, we did say that the lungs aren't the highest priority patient. However, airway is very high on the priority. So if you ever see that your patient's struggling with airway, I say address that first. Okay. Not just shortness of breath, because sometimes it's expected that a patient will have shortness of breath based on their disorder. All right. For example, a COPD patient may be short of breath generally. So the fact that you see SOB or shortness of breath, you don't necessarily consider that patient to be your highest priority patient in a list of patients who have other things going on. Okay. Now, with that said, airway is important. Sepsis. All right, so this is Ask Graph. That's the mnemonic developed by Dr. Zishan Hoodboy with, I think it's NCLEX High Yield. So I got this off of Pinterest. But that said, it's really good. That's why I want to share it with you guys as well. Sepsis, that's important. Sepsis, and we're going to talk about septic shock in a moment on another mnemonic that I'm going to share with you. But the K here is for potassium, because changes in the patient's potassium can be a priority setting event, right? If you notice that it's too high or too low. Why? Because it involves the heart. Potassium is one of those electrolytes that directly implicates heart problems. Okay, so potassium, big deal. Keep it in a tight range. And if you notice that it's not in its range of, put it in the chat for me, what's the range for potassium that we like to see? The normal range, right? Because if you see that, excellent. Excuse me, excellent, Wendell, excellent, Carissa, excellent, Melissa, right? You want to have it just like that, so that you understand when you see that that potassium is too low or too high, because it's usually going to have an implication for the heart. Okay, glucose, we already mentioned the importance of catching hypoglycemia. All right, I would love for you guys to share a couple more hypoglycemia signs that you might notice in a patient. We've already mentioned shakiness. We've already mentioned diaphoresis. There are like 6 that I want you to feel comfortable with. All right. What are some other signs of hypoglycemia? Because we never want to mix it up with hyperglycemia, and we never want to be so vague that we don't have the essential hypoglycemia items. Altered mental status, yes. Carissa, that can be, Wendell has dizziness in there. Anything kind of involving that little feeling of dis-ease where the patient is a bit confused. All right, so confused would be up there with altered mental status. And the reason that the patient is confused is because they're not getting enough blood sugar to the brain. And so the brain needs oxygen and blood sugar in order to survive, or glucose, right? In order to survive, or else it's going to shut down and you're going to start seeing a mental deficit. So confusion is the mental deficit that comes from not enough blood sugar feeding the brain in order to help it do its maximum function. So it starts just kind of going into low power mode, right? Where the person can only give you but so many responses that are appropriate. Some of them are going to be inappropriate. So altered mental status. Yes, yes, yes. All right. Anything else in there that you want to include? I have a couple of cheat codes down here, right? Hunger makes sense if you're, well, actually, no, hunger does not make sense. Please do just scratch that. That's more of a hyperglycemia sign. Hunger is not something people feel when they're hypoglycemic. As a matter of fact, you would think whenever a person's hypoglycemic, they would just eat voluntarily, right? But that's usually not the case. They're so confused, often they forget what's happening to them. So it's usually the nurse or some other loved one who realizes what's going on, who comes in to remind them to eat. Okay. Hunger, though, especially voracious hunger where the patient cannot stop eating, also known as polyphagia, is what hyperglycemia is all about. So knowing the signs of hyperglycemia versus hypoglycemia will be essential. And does NCLEX like to give you the differences in those questions, right? Give you a select all that apply question that says, which of the following are the signs of hypoglycemia? And then they shove some other ones that you get confused with, that with hyper and hypoglycemia sometimes. Yes, they will absolutely do that. So know those distinctions, okay? Usually, Mark K says drunk and in shock. I like that. If the patient's behaving like they're drunk and in shock, it's hypoglycemia. Whereas and by drunk and in shock, we mean confused, irritable, slurred speech, right? All the things that staggering, all the things you might see in a drunk person. And the shock piece is tachycardic and hypotensive. All right, that's the shock piece.